Thank you for waiting, everybody. I think we'll start with the program now. So just welcome everybody first, and thank you for joining today. Can I just ask that unless you are presenting, could you please ensure that you're on mute and that your camera is turned off as well, just so that we can see who's presenting and the presentation a little bit clearer. So if you are in a room with more than one person, can I please ask you to put the name of other people that you might be with in the chat? And as we go throughout the presentation, or rather the learning today, we'll be having a Q&A session at the end. So if you have any questions, rather than asking them at the time of the presentation, could you please enter into the chat box? And what we'll do is we'll read those questions out on your behalf at the end of the session, where our expert panel who is presenting today will be able to answer those questions for you at the end. So I'm just going to ask each presenter today to just introduce themselves, and then what we'll do is we'll then start with Tuti, who will be presenting the first item today. So Tuti, can I ask you to introduce yourself to the audience today, please?
Hi, good afternoon, everybody. My name's Tuti Boiser. I'm the Director for Nursing and Midwifery for the Southeast Genomic Medicine Service Alliance. Great to be here.
Thank you. Dominic?
Hi, everyone. My name's Dominic. I'm the FH project nurse for the North Thames Genomic Medicine Service Alliance. Nice. Thank you for inviting me.
Oh, thank you. Laura?
Hello, everyone. My name is Laura Monge Garcia. I'm a nurse practitioner at St. Mark's Center for Familial Intestinal Cancer, and I'm also the national lead nurse for the Lean Syndrome Project.
Thank you. Pooja?
Hi everyone, I'm Pooja Dasani. I'm a principal genetic counsellor based at Great Ormond Street Hospital and genetic counselling lead for North Thames GMSA.
And finally, Damisha.
Hello, my name's Damisha Cho and I'm the lead pharmacist at the North Thames Genomic Medicine Service Alliance. Hi.
Great, thank you, and thank you again for coming today and for all your hard work in putting this presentation, this learning event together today. I'm going to start by sharing the screen now. Now I will scroll through the slides, so please let me know when you'd like me to move on. If you'd like to take control and scroll through them yourselves, that is absolutely fine. Please just request your control and I'll let you have that.
Okay, shall I make a start, Nate?
Oh, please do, yes. Yeah.
Okay, next slide, please. So today we're talking about genomics in cancer care. Oh, the next back, please. We're talking about genomics in cancer care. And again, it's a pleasure to be here. Thank you to our partners and to Nate for inviting us. And so excited to be here with our wonderful audience virtually. So I'm actually presenting on behalf of two GMSAs, Southeast Thames and North Thames, and my counterparts, Natalie and Maria are sorry they can't make it today, but I'm sure you will meet them in due course. So today we're going to talk about transforming care through the Genomics Medicine Service Alliances and your role in that. Next slide, please. Next slide, please, Nate. Yeah, so first things first, just some definitions. So we know a lot about genetics. I think that's a more familiar word for us. So it's a study of heredity and study of the function and composition of single genes. Now we're moving on to genomics, which is the study of an organism's complete set of genomic information, and it's end-to-end and includes both genes, coding and non-coding DNA. So you're going from a sort of a smaller set of material to just the bigger sort of picture in the whole organism. And next slide, please. And genomics has been around for a while, so I think this really kick-started when we had the 100K Genomes project, which many of your patients might have participated. And then, I'm sorry, and that's now powered by these three sort of policy drivers. So the first one, I'm sorry the picture is a bit stretched there, is the annual report of the Chief Medical Officer talking about Generation Genome. And this is really about us being the generation to really take advantage of genomics in healthcare. And then again, the NHS long-term plan, which really emphasizes precision medicine and personalized care. And then on to Genome UK, the future of healthcare, which has the ambition for all healthcare professionals to have the skills and the knowledge to make sure that our patients benefit from genomics. So genomics is not the future, it is here today. Next slide, please. Okay, so just some good news that has recently come to the fore. You might have seen this in the news. And there's a new development for non-invasive prenatal testing, and this is about assessing early for the risk of developing retinoblastoma, so babies can get early treatment for this condition. And next slide, please. And then the gene drive mTRNR1 ID system, which has just been developed for point of care testing to detect this polymorphism in newborn babies. When newborn babies have sepsis, they have to be given antibiotics within an hour, but some who have this polymorphism can become deaf. So with this new development of technology, we are able to check for this polymorphism and make sure we give alternative treatment within that time frame to prevent the other consequences of sepsis. So on the next slide, please, you can see here this little girl who has had the benefit of this test and is actually healthy and thriving and not had the issues of having deafness as a result of antibiotic treatment. And this is just a few of the developments that we have. So what is the Genomic Medicine Service Alliance? So we are a wraparound organization really to support the genomics laboratory hubs, the clinical services to support the systematic embedding of genomics into routine clinical care, facilitate rapid adoption of scientific advances like the ones that you just heard in the last slides, and through collaborative partnerships working across disciplines and geographies. And this is to bring about personalized medicine and care plans. So there are 7 GMSAs across England, and I put all the contact details of the lead nurse, and sometimes they also have a lead midwife. So wherever you find yourself, you will have a nursing lead to support you in your any projects you have or knowledge needs for genomics. So next slide, please. So within the transformation projects for the NHS England Genomics Transformation Project, nurses and midwives are a priority. And that's really important because we are the largest section of the NHS workforce and best placed to optimize the contribution of genomics to improving health. It's also in our NMC proficiency standards. So we are expected to have a level of knowledge and skill in delivering genomics within our practice area and scope. The good news is there are many already involved in genomics in specialized roles, particularly those of you who are probably specialist nurses or advanced practitioners. This probably touches on you a bit more, but there is a need for general awareness and a genomics mindset that is needed for all. And we need more nurses like you to lead in this field and ensure equity of care. Next slide, please. So if you're ever curious or want to know what types of conditions can be tested, we have the National Genomic Test Directory. So this will tell you the tests available in the NHS in England for rare and inherited disorders and for cancer. And it tells you the technology platform which each test is delivered. And there's a clinical eligibility criteria that a patient must meet to enable testing, and also this is also funded, and that's the link at the bottom. So genetic test is there for everybody who is eligible for testing. Next slide, please. But we say that genomics is for all, but is it accessible to all? So Nate, you can click on this fully now. Yeah. So if you think about conditions, so like cardiomyopathies, it's very close to my heart because I'm a cardiac nurse. It's a very common inherited condition, yet many are still in general cardiology clinics or heart failure clinics, not really getting that diagnosis that's causing their heart failure. And the same is for polycystic kidney disease. There are way too many patients in general renal clinics and not getting the true cause of the polycystic kidney disease and getting the appropriate treatment. Now, Lynch syndrome, which Laura will be talking about, whilst the diagnosis rate is probably getting better, about 40% of eligible relatives are not tested. In familial hypercholesterolemia, which Dominic will be talking about, there's a frightening statistic that 8% of the population is currently identified. That's frightening, considering that it affects 1 in 250. And this is an American study, but a proportion of African American breast cancer patients who meet criteria for genetic testing do not receive it as part of routine care. So think about what's happening in your clinical area, and where are the sort of inequities there. And Nate, just the last one, please. For the maternity example, so in a sample of unexplained births, about 8.5% could be attributed to genetic disease variants. So there is that potential for having parents, having the reason for the reason that their child has died, but also for them to plan for their next pregnancy. So think about there is still a lack of equity in access to genetic testing, and nurses and allied health professionals do play a role in supporting this, also to prevent sudden death, complications, and also other family members from having consequences of an inherited disease. Next slide, please. So for nursing and midwifery, there are some priority projects within our remit, and mainly we're looking at pathways and the nurses' role in that, your practice as nurses, and the competencies needed to make sure that you're able to engage in that pathway, fulfill your role in that pathway into genomics, as evidence-based and as best as you can. So we have some priority sort of areas, and you'll be glad to know that cancer is being looked at very closely. So we've got a project around breast, lung, colorectal, and ovarian. And then for rare diseases, there's neurology, particularly focusing on familial epilepsy, and also polycystic kidney disease, and there's a fetal-maternal project that's ongoing. We also have projects focused on familial hypercholesterolemia, monogenic diabetes in the young, and sudden cardiac death. So quite a lot of disease area, but I'm sure the cancer ones will be of most interest to you. And next slide, please. So currently, the first one sort of in the cycle of projects is the lung cancer national scoping exercise. So what we are doing is first approaching cancer alliances to look at and understand the lung cancer MDT activity in the region. We're approaching specialist nurses to make sure that they're involved in sort of shaping and letting us know what is happening in their patch. And then we hope for them to participate in a national scoping exercise, identifying touch points along the care pathways where genomics could be, and the conversations around genomics can be had. And the first national forum will be on the 25th of May. So we are hoping for 2 representatives from each GMSA to participate in this scoping exercise. So I see in the audience one person who I've already invited, I think. So if you are interested, please get in touch with us, and we'd really, really value your participation, because we want our voice to be heard, for our region in this national scoping exercise. Next slide, please. And we're not only doing things for people already in practice, nurses already in practice, but we're also working on the pre-reg education for genomics. There is a Pan-London Health Education England GMSA education working group, and that working group has prepared the core principles for pre-registration curriculum. This is already agreed and will be kind of the sort of cross-cutting theme across the curriculums. So at every sort of topic or area, there will be some genomics within the pre-reg nursing curriculum. So our next steps, and particularly for those who are allied professionals in the audience, is a call for allied professional representatives from the universities, but also the healthcare providers to review your curriculum. We also are thinking about collaboration to review curriculum for physician associates, and then of course develop new content and signpost to educational resources to support delivery. Now, this is really important because it's really good if the education resources are bespoke to you. So let's say you're a physiotherapist, you're a radiographer, this is really important, that any genomics education programs are tailored to you. The next slide, please. Okay, so this is our ask, is really to think about what genomics applies to your practice. So if you look at that patient pathway on the left, you've probably got a role in, one of these stages, or sometimes all of these stages. So have a think about how genomics fits into your practice. Could it be in, delivering a precision treatment? Could it be in supporting your patient, opening up conversations with like an inherited cancer? Could it simply be just supporting a collection of a specimen, a blood specimen or tumor specimen, to make sure that genomic testing is done? Or, simply looking at the cluster of signs and symptoms that your patient has, and it's not quite fitting a particular picture. Could this be an inherited or a genomic condition? Next slide, please. And then, of course, to support that, please take part in genomics training and education. So the genomics education program, there are links here on this slide, but it's a whole array of from bite-sized sort of what is genomics, how to order a test, to full-on, fully funded MSc. So if you want to get an MSc in genomics, here's your chance. It's actually free, fully funded. There's also webinars for health visitors. Of course, there's the patient stories to really bring home the impact of genomics, and there are additional courses on the Future Learn platform. Next slide, please. And North Thames GMSA has a mainstreaming genomic medicine program, and it consists of online sessions that will support you in consenting patients for testing, requesting genetic tests, and communicating results to patients. And you can see here, there's a lot of dates up from June to September. So contact Hannah if you're interested in participating in those. Next slide, please. And of course, get in touch with us. There's more resources from the websites, and we've got lots of announcements on Twitter. And on the left is the Southeast Genomics website, and on the right is the North Thames GMSA website. And don't worry if you get caught between the two. I'm sure if you need any specific information, we will point you to the right GMSA. And next slide, please. And of course, we'd love to hear from you. What we really want to see is where nurses are making a difference in genomics care for their patients. So let us highlight you, support you, and champion you, and get involved in our project so that we can develop also, have that voice and develop the next nurse leaders in genomics. If you have any questions, have any training needs and bespoke training needs, we're there for you. And particularly if you want to have more mainstream genomics in your hospital or in your specialties, do get in touch. And there's the 2 emails for North Thames and Southeast. So please reach out to us. Next slide. And I think that's it. So thank you very much. And I'm happy to answer any questions at the end of the session. Thank you.
Hi everyone, my name's Dominic. So I'm the FH project nurse for North Thames, and I'm working on the FH pilot, which is one of the transformational projects which is trying to mainstream genomics into our practice. So mainstreaming genomics is really about harnessing the power of genomics and integrating this technology and knowledge into our daily practice. And what we're trying to do is improve diagnosis. We're trying to improve treatment options for patients and overall the outcomes for the patients and the population as a whole. So this is all to try and fulfill some of the NHS long-term plans. And so this is to increase, improve. One of them is to improve detection and treatment for high-risk conditions. And one of those is FH, which is a really good sort of way to showcase the power of genomics to do this. So this pilot is really to try and evaluate screening of FH in primary care, so in GP practices. So assessing the ability of case finding tools to do this, as well as implementing the genetic tests for FH in primary care. This test would normally be done in a specialist clinic, and by doing this, hopefully in primary care and GP practices, we're trying to speed up this process and get people started on treatment earlier. So what is FH? FH stands for Familial Hypercholesterolaemia. So that's really just a fancy way of saying high cholesterol that runs in families, that high cholesterol in your blood that runs in families, so it's got a genetic component. I'm going to call it FH just because familial hypercholesterolemia is a bit of a mouthful. But so FH is a genetic condition. It affects the ability of the liver to remove excess cholesterol from the blood. It's inherited in an autosomal dominant pattern. So that means that you only need one disease-causing gene to have FH, and there's a 50% chance that you will pass that on to any offspring. The three main genes affected are LDLR, ApoB, and PCSK9. And it's actually much more common than we ever thought. So it's actually estimated that 1 in 250 people have FH, and only about 7 or 8% of those have actually been diagnosed. And so the NHS long-term plan is quite ambitious, and we're hoping to increase detection to 25% by 2024. But we'll try our best. Okay. Why do we want to identify FH? So we know high cholesterol is a massive risk factor for cardiovascular disease, and these patients with FH have high cholesterol present from birth, and this increased sort of cholesterol burden over their lifetime gives them a much higher risk of having premature cardiovascular disease. So they have this fatty cholesterol in their blood, and it builds up these fatty plaques, causing atherosclerosis, and that can cause heart attacks and strokes. And that risk factor for patients with FH, if untreated, it's really high. So about half of men with untreated with FH will have a heart attack before the age of 50, and about a third of women before they're 60. And you wouldn't really know that you had FH unless you had a blood test for your cholesterol. But actually, FH is really treatable with simple lifestyle, healthy lifestyle, and healthy diet, and simple treatments with statins. By reducing their LDL cholesterol, so that's the bad cholesterol, by 1 millimole, that reduces the incidence of cardiovascular events by about 25%. However, the average age of diagnosis of someone with FH is actually about 47 years old. So that's really just a missed opportunity with all these people living with FH, where we could have hopefully identified it sooner and implemented the simple treatments to reduce that risk of heart disease to the normal sort of population level. So the benefit of genetic testing for familial hypercholesterolemia is really what we're doing is we're confirming the diagnosis. We're saying you've got this genetic change, and that's causing this high cholesterol that you are experiencing. And what we can do then is optimize their treatment, because they've got this lifetime exposure of high cholesterol. We treat them quite aggressively, and there might be other treatments that we can offer them that we wouldn't otherwise have been able to, especially in the future. As I said, there's a 50% chance that their first-degree relatives will also have the same genetic cause of FH. So what we can do is cascade screen those first-degree relatives. So that's their parents, their siblings, and their children. We can see if they've got FH and then start treatment earlier. And this is all really a move to a more proactive healthcare system, where we're being proactive instead of reactive and only testing people once they've had a heart attack and things like that. And hopefully by doing this, we'll improve the population health overall. Here, this is just as a family tree or pedigree. This arrow indicates the index case. So we've tested this person. We found out they've got FH. Well, as I said, they will definitely have got this from one of their parents, depending how friendly their milkman is. But yeah, so this mum has got FH, and then we can test the siblings. This sister has FH, and they've passed it on to both of their children as well. So it's just a really cost-effective way of identifying FH and other people in the family. I won't bore you with this too much, but this is the proactive care framework for FH case finding, which is we're using it in primary care and GP practices. So part of my role is to upskill nurses and pharmacists in order to screen their list of patients for patients that might have FH. So there's two sides of this pathway. This side is looking at patients that have been coded with FH, so they have a diagnosis of FH on their records. We're going to look at their records to see if they've had a genetic test. If they haven't, we're going to offer them that genetic test in primary care in the GP practice, and then cascade that other family members from there. On the other side, we're looking at patients who are really at high risk of having FH. So they've got they've had a blood test in the past that showed that they had a really high level of cholesterol. We're going to invite them in for blood tests and a questionnaire to exclude any other causes of high cholesterol, and potentially also see them face to face to look for any physical signs that they might have this raised cholesterol. If they meet this criteria for testing, we'll then offer them that test in primary care, and then again cascade from there. So I just thought I'd briefly show you what the physical signs. So the people with FH, that their cholesterol levels are so high that their cholesterol can deposit in different places. So you can get what's called tendon xanthomata, which are these swellings on the tendons and knuckles and knees or the back of your Achilles. You also get xanthosoma, which are these yellow lumps around eyes, and a corneal arcus, which is this white ring that you can see in the iris of patients. Xanthosoma and corneal arcus they're quite common in people as they get older anyway. But if you were to see this in someone who was under the age of 45, that's quite a good indicator that they've got raised cholesterol and might have FH. Here, there's some more pictures of the tendon xanthomata, so you can have a look at your knuckles now and see if you've got any lumps around here, or if you feel the back of your Achilles and if there's any lumps like that, maybe go see your GP and get your cholesterol tested. I thought I'd just end here. Yeah, so this is one of the case studies I use when I do the training with the nurses and pharmacists. So this is Mona. She's our poster girl for FH, and she actually died at age 37 of unknown causes. And you can see here that Leo has painted this xanthosoma here, and on this side, on her hand, there's potentially a bit of a lump there, which might be a tendon xanthomata. So really, what we're thinking is, oh, maybe Mona had FH. Thank you very much, everyone. Let me know if you have any questions at the end.
Thank you very much, Nate, for giving me the opportunity to present today. So today I'm going to be presenting the National Lynch Syndrome Project. Let me see if I can have control. So what I'm going to be talking about today, as you can imagine, I'm going to be talking about Lynch syndrome. A little bit, I'm going to do a brief introduction. Let's see if I can. And then after that, I'm going to be talking about, it's not so, okay. And then I'm going to be talking about the benefit of this project to your patients and their family members, and also to your service, because there is a benefit to your service. And for people that worked in the colorectal or gynecological cancer, MDT, I'm going to ask you to take advantage of the training opportunities available. There is online training, and also to get in touch with your Lynch syndrome champion if you have one. And if you don't have one and would like to become one, please do get in touch with me. And also, even if you have one and you will also like to join forces with your champion to try to improve the diagnostic pathway, I will really encourage you to do that, because two is better than one. And just to remind you that we have a specialized Lynch syndrome service, and we accept referral from all hospitals. So Lynch syndrome is a cancer predisposition syndrome. What does it mean? It means people that has a genetic alteration in one of the Lynch syndrome genes have a higher likelihood to develop certain types of cancer. The main concerns in Lynch syndrome is colorectal and endometrial cancer. So as you can see from the picture here, in dark blue, you can see the risk of colorectal cancer in the general population, and in light blue, around here, you can see the additional risk or likelihood to develop colorectal cancer that people living with Lynch syndrome have. So as you can see, is quite significant. As you can see, it's also quite significant, the risk or likelihood to develop endometrial cancer. So it's something that we need to take quite seriously, and there is something that you can do about it. There is also a risk to some other cancer types, but the risk is not as high as others. So the risk to the other cancer or least frequent cancers are ovarian, urinary tract, gastric, small intestine, hepatobiliary and pancreatic cancers, sebaceous gland and adenoma, skin cancer, and CNS tumors. Lynch syndrome is also inherited in what we call an autosomal dominant manner. What that means is that the first degree relatives, that is the parents, siblings, and children of someone affected, have a 50% chance or 1 in 2 chance of having the same condition. The reason why it's so important to identify people that have Lynch syndrome is because there is something that we can do about it. There are personalized cancer prevention programs available to them. These cancer prevention programs include a 2-yearly colonoscopy with polypectomy to prevent the risk of colorectal cancer. We also know that taking aspirin for a minimum period of 2 years reduces the risk of colorectal cancer and probably to other cancers in patients living with Lynch syndrome. One-off testing of H. pylori in patients with Lynch syndrome might reduce the risk of gastric cancer by up to half. There is also lifestyle recommendations. Also for women living with Lynch syndrome, there is prophylactic surgery and also additional family planning options that will ensure that they don't pass on the genetic alteration that causes Lynch syndrome. And if you have a patient that have a diagnosis of colorectal cancer, there is adapted and recommended surgery that can prolong their life and reduce the future rates of colorectal cancer, and also personalized treatment or target treatments such as immunotherapy. And I will talk about that very shortly. So why the National Lynch Syndrome Project? So the Lynch Syndrome Project goes alongside the NHS long-term plan, the NICE guidelines, and it's a fast and effective way to identify and refer patients that might have Lynch syndrome. The main aim is increased identification, and the reason why is because we only know about 5% of the patients that have Lynch syndrome, which means that 95% of them, they're walking among us and they're not taking advantage of their personalized cancer prevention programs. As I mentioned, there are benefits to the patients, their family, and your service, and there are target treatments and surveillance recommendations that they might be missing out if we don't identify it. As part of the National Lynch Syndrome Project, what we have developed is some flowcharts to help teams to identify these patients. And also the aim of these flowcharts and the project is to make every single step of the pathway automatic. So by the time the patient gets diagnosed, everything happens in a timely manner without anybody within the NDT having to do much about it or send request form or anything like that. So by the time the patient gets discussed within the MDT, you have enough information to choose the right treatment for them, and also to refer the patients that are eligible for genetic testing for Lynch syndrome. I'm not going to go through the flowchart at the moment. As part also of the project, there is an optimal part or an optional part of the project in which we provide training to clinicians that might wish to offer genetic testing for Lynch syndrome in routine cancer clinics. And if you are interested in that, please do get in touch with me. I will put my email address in the chat shortly. And why is it important? Well, apart from what I said before, that we only know about 95% of the patients that have Lynch syndrome is actually Lynch syndrome. You will be surprised to know that it's actually the most common cancer predisposition syndrome. It is more common than BRCA, but we don't have someone like Angelina Jolie to raise awareness. And to illustrate how important it is for the patient that you may have in front of you to have that diagnosis of Lynch syndrome, I'm just going to tell you a little story of Moheg. Moheg is a real person, and he has written a book about his story. So Moheg, you can see him here, he was diagnosed with colorectal cancer at the age of 31. He was very lucky because of he talked about his family history, and he was referred for genetic testing and he was identified having Lynch syndrome. He had 18 cycles of very toxic chemotherapy that didn't work. He also had a major operation, ileostomy, radiation, you name it. He had it all, and then eventually he was given 6 months to live. At the time, this is quite a long time ago, he learned that immunotherapy offered a good chance of survival to patients with Lynch syndrome, and he had to fundraise for it. He eventually had immunotherapy, and that cleared all his tumors, and he's still alive and telling the tale, and that's why he has written this book. So this is one of these stories that can really illustrate how important it is, that diagnosis. And to make the picture a little bit more clear, I would like to compare what could happen if he actually followed the traditional cancer pathway and what could happen if he followed the genomics care pathway, because he is right in between. So in my view, if he followed the traditional cancer pathway, he would have been diagnosed again at the same age. Maybe someone would have asked him about his family history, maybe not. Maybe he wouldn't have been referred for genetic testing. He will still have his 18 cycles of toxic chemotherapy that didn't work, still same treatment. He will have given 6 months to live, and if he didn't have the immunotherapy, I don't think he will have survived. So this is very important to take into consideration what a diagnosis of Lynch syndrome, what sort of effect can have into someone's diagnosis and treatment. And if he followed the genomics care pathway, now anyone with a diagnosis of colorectal cancer under the age of 40 is eligible for genetic testing for the colorectal cancer panel of genes, which include the Lynch syndrome genes. So he will have been diagnosed much sooner. As soon as he starts his treatment, as soon as the cancer will have progressed, he will have been switched to immunotherapy now. So obviously he will have less side effects, he will have a better quality of life. Maybe he wouldn't have needed the radiation and some of the treatments, unnecessary treatment that he had at the time. So, you know, in terms of quality of life, it will have been much better. His family members will have been identified in a timely manner, and he is now having his personalized cancer prevention program as well as his family members. So if you compare both pathways, I'm sure you can see that if you would like to make a difference to your patient's life, this is your opportunity, because the difference could be from non-survival to the survival of the patients that you have in front of you. In addition to that, for every Lynch syndrome patient that we identified on average 3 family members. So you are not just saving the life of the patient that you have in front of you, you are probably preventing 3 other cancers in 3 family members, and you might be saving 4 lives. So this is why it's so important to identify patients with Lynch syndrome. It does make a huge difference. So just my last slide, just to let you know that there is online training available. There is the option 1 that will help you to go through the pathway, identify patients with Lynch syndrome, and refer them to genetics. They are very short. You can see 5 minutes, 6 minutes, 7 minutes, 12 minutes. So you should do it in under an hour. If you would like to offer genetic testing to patients with Lynch syndrome in routine cancer clinics, then undertake option 2 and get in touch with me, and I will make sure that you get the support that you need to be able to offer genetic testing for Lynch syndrome. Thank you very much. You can contact me through that email address, or I will put my own personal one in the chat. Thank you.
I'm Pooja Dasani. I'm a genetic counsellor, and what I want to talk about is really collating all of that, because you've had such a lovely overview of the different projects that are a part of the GMSA, and such a big difference that genetic testing can make. And of course, you know, being a genetic counsellor, I'm certainly an advocate for that. You may have heard all the way through sort of change in terminology, genetics, genomics. Realistically, we're all talking about the same thing. There isn't really that much of a difference. It's just a matter of how we do testing now. So next slide, please, Nate. So you've already seen, Laura was talking about, you know, the Angelina Jolie effect, but in reality, genetics and genomics is everywhere in the media. You couldn't go a day without some news article about genetic testing and how it's changed medicine. You may recognize some of these already, from Angelina to Stephen Sutton, and the most recent piece of news about sort of genetic testing to detect rare retinoblastomas in unborn babies. That was only sort of set up in the test directory in the last iteration in April, so it was in the media a couple of weeks ago. So it is, of course, awareness is raising, everybody's talking about it, patients are asking about it. So realistically, there is a massive need for us to do something about that, and to help support that awareness and address that. Next slide, please, Nate. Thank you. So as I said, we need to address some of that patient and public awareness, but also there is a need to detect disease at an early and curative stage, as Laura quite well sort of illustrated with Lynch syndrome, but similarly with other cancer conditions, and identify at sort of at increased risk of cancer. So you've talked about family members. So these are well individuals who may be at an increased risk of a cancer, and we need to identify those and put management and screening plans in place for them. And of course, offer targeted surveillance and treatment. Now, putting that into context, in the traditional pathway, you know, these patients would have been diagnosed with a cancer, possibly having their treatment plan, and alongside a genetics referral may have been made. Now, in clinical genetics, about 30 to 40% of all referrals that we see are associated with cancer. So it's quite significant, yet not the bulk of our workload. So that really provides us with a rationale to actually embed genomic testing within the cancer diagnostic care pathway, so that we can try and address some of that testing within their treatment plan, rather than done alongside and creating a separate pathway for it. Next slide, please. Thank you. So there are two types of genetic variants that you may have come across within your practice. You may have heard this before, but all cancer is genetic, not inherited. So what that really means is, if you were to test a tumor or a cancer, you would find genetic changes that is actually the cause of that cancer. These are called somatic variants. However, those variants would not be present in other cells of the body, they would not be present in the gamete, and are usually not inherited. But you still need to recognize those, and that testing still needs to occur in order to target that treatment plan. However, in about 5%, maybe 5 to 10%, depending on the cancer type, in a very rare proportion of cancers, these changes, these genomic variants, are not just present in a tumor, but actually in all cells of one's body. These are called germline variants. So this is what people usually talk about when they're talking about genetics and cancer, the ones that are inherited where it has implications for other family members. But these are rare. And these are, of course, important not only for their individual's treatment, but to recognize and identify individuals who might be at an increased risk in the future. Next slide, please. So as I mentioned there, you know, 5%, roughly 5% of cancers can be inherited or genetic, but of course that depends on the type of cancer. Now, if you're looking at a paraganglioma, for example, about 40% of paragangliomas can be inherited, compared to an ovarian cancer, about 15 to 20%, depending on the type of ovarian tumor. So it does depend, and genetic testing can be available for many different tumor types. Next slide, please. I won't go through this in a great deal of detail, because Laura quite very, very well suggested how we could use the mainstreaming rationale in Lynch syndrome. Similarly, it can be used for other cancers. But the first example of mainstreaming or genetic testing done at the point of care was really within ovarian cancer. And there's a lovely report written on that, where if we had gone down the traditional pathway, creating two routes, so a treatment plan yet a referral to genetics at the same time, by the time a patient might get a genetic test results, you're looking at about 20 to 24 weeks of their treatment plan, versus if you're going down that route of A, where you've offered genetic testing to individuals who were diagnosed with an ovarian cancer or a cancer of any other sort, actually that identification of the genetic test result would be at a much earlier stage, maybe at about 6 to 8 weeks, which then allows us to plan for the treatment, but also identify other family members, at which point you would then make that referral to clinical genetics. Next slide, please. And the test directory very much supports that. So we heard earlier about the different genomics laboratories, and actually each of these laboratories are now able to offer genetic testing in the same manner for any individual at any part of the country, compared to in the past where, depending on where you lived, you were offered a different kind of test. It also talks about who can offer this test. So again, in the past, it would usually be done only by clinical genetics, but actually now it does talk about mainstream clinicians, so oncologists, surgeons, CNSs, allied health professionals who can offer genetic testing for certain genetic conditions and cancers. So it's worth looking at that test directory and see where you fit. Next slide, please. So what we're all doing is really thinking about patient, keeping the patient in the center of this entire pathway, but embedding genomics within the MDT practice. So all of us have a different role within genomics, yet we're all doing all of those kind of genomic elements to support the treatment and management plan. And of course, what we can do within clinical genomics is actually support you within that process. So we've talked a little bit about some of the education that we can provide, some of the consent training, some of the sort of testing and planning and pathway planning, how you embed that within your own setting to support that. Next slide, please. And of course, working together and managing roles and responsibilities to ensure safe practice. So we each have a role within this. As an individual, as a health professional, addressing those patient concerns with genomic testing, but within our own remits, and of course, sharing that responsibility as a team. Next slide, please. What we do within genetics and genomic counselling is we would still see these families where there isn't a clear-cut diagnosis to be made. There's not a clear-cut test to be offered, but we'd make that risk assessment. We'd arrange management and screening appropriately, support patients in adjusting to this genetic diagnosis if there is one, and ordering appropriate further tests if needed. We're a part of the MDT and support variant interpretation. And usually we're more involved in sort of joining up services for patients. So an individual with a genetic diagnosis may need different screening pathways. So we're trying to talk to different clinicians across the board to join up these services. And of course, helping with difficult conversations within families. Next slide, please. Some of the common questions that we get asked in cancer genetic counselling, you can go the whole way through, Nate. Thank you. Are just listed there, but more often than not, people are terrified of what it means for them. This is a long-term diagnosis rather than a simple treatment plan. This is a permanent diagnosis when a genetic change has been identified. So we help address some of those questions and concerns as they go through their life, and help support them within that family. Next slide, please. So we are experts in working with these patients and families, making assessments, supporting families seeking a genetic diagnosis, and offer pre and post counselling. And of course, as I said, we can support you as clinical teams in education and training, and of course, embedding genomics in your practice. So I would really highly encourage talking to your local genetic counsellor, whoever that might be. If you're not sure, you're always welcome to contact me. And then my final slide is just about some further resources, as we've talked about before. And please contact myself or Hannah if you do want to try and learn how you embed that within your own practice. Thank you.
The final part is about personalised medicine and pharmacogenomics and the pharmacy role. I'll be dominantly talking about pharmacogenomics, and in particular one pharmacogenetic test at DPYD. Go to the next slide, please. So before we start, what is pharmacogenomics? So pharmacogenomics combines pharmacology, so the science of drugs, with genomics, the study of its genome and its functions. So the overall aim is to use a person's genomic information to identify the most effective drug for them and to reduce side effects and select the ideal dose for them. And essentially that can be split into three main areas. So one, indication-based testing. So for example, if you had a patient with non-small cell lung cancer and they have an EGFR mutation, they can be treated with olatinib. And you have a range of different types of indication-based testing within oncology. The second is contraindication-based testing, where if you give a drug that at risk of a side effect, and an example of this is abacavir, which is used for HIV, and if a patient has a genomic variant called HLA-B5701, they're at greater risk of hypersensitivity reactions. The other final one is dosing-based testing, which kind of alludes back to contraindication-based testing, but this is where you would have a test and you would require a dose reduction or a dose increase. An example of this is fluorouracil chemotherapy and DPYD testing. Next slide. There are a number of pharmacogenomic guidelines available. So these guidelines are created globally by the Clinical Pharmacogenetics Implementation Consortium, and they produce guidelines for particular enzymes or particular genetic traits and what we should do with the drug and the dose. So there's one for antidepressants, for voriconazole, tacrolimus. There's these for the one that been alluded earlier, so aminoglycosides, and the testing for their antibiotics and whether it's contraindicated. Next slide. But the one we'll be focusing on is from a transformational project that we have done in 2021, and it's for DPYD. So DPD stands for dihydropyrimidine dehydrogenase, and this is an enzyme. This enzyme is coded for by DPYD, and it's an incredibly important enzyme involved in the metabolism of 3 chemotherapy drugs, 5-fluorouracil, capecitabine, and tegoprazan. And they are commonly prescribed in GI, breast, and head and neck cancers. So if you have a DPD deficiency, it's caused by inherited variants of the DPYD gene, so germline mutation. And if you have this mutation, you have increased risk of serious and fatal toxicities such as diarrhea, mucositis, neutropenia, and neurotoxicity. Next slide. So the MHRA alert in 2020 produced an alert, and they stated that up to 17th of June 2020, the yellow card scheme received 30 reports of where there were fatal outcomes that describe a known or suspected DPD deficiency with fluorouracil and capecitabine. And it alerted all oncology healthcare professionals that you should be testing for this gene before you be given treatments of fluorouracil-based therapy. So patients who have a DPY deficiency reporting the pharmacogenomic test will need to have a dose reduction, especially if they're heterozygous, where they have, we get 2 genes from a family member, one from mum, one from dad, and where if you have a deficiency in one, you'll have a dose reduction. If you have a deficiency in 2, you would not be able to have the anti-cancer treatment, and an alternative treatment would be required. So this test is commissioned by NHS England, and as a multidisciplinary team, we need to work together to ensure that a test is requested in a timely manner and that pharmacists advise the medical team on the dose reductions needed, so to help each other out here. In June 2021, a national audit was conducted within the GMSAs to conduct a baseline understanding of our pathway for the testing across all tumour indications. So if we go to the next slide. So the results are available, and we analysed the results within our team, and the national survey was completed for North Thames GMSA in September 2021. And it was essentially to determine whether there was geographical variation and barriers to accessing the testing pathway. So within North Thames GMSA, we have 14 cancer providing trusts which provide a fluoropyrimidine-based treatment. And we found out reassuringly that all trusts do undertake DPYD testing before the initiation of treatment. And all tumour indications were tested. So it wasn't that some centres were just doing breast cancer, others were just doing GI cancers. There were 2 out of 14 trusts sending DPYD tests outside of North Thames Genomic Laboratory Hub. And this was important to highlight because if you send a test outside of your regional genomic laboratory hub, it won't be commissioned. So turnaround times, and this is important, this was found to be quite variable. So it ranges from less than 2 days to approximately 6 to 10 days. However, 6 to 10 working days is still a good time frame considering the volume of tests that we have done. But essentially what we did is we returned all our results back to the individual trusts, and those that had longer turnaround times, we were able to map an ideal pathway and what they could do to improve their pathways. For example, it could be as simple as changing their delivery system to the Genomic Laboratory Hub. However, it raised other questions of how we need to identify further variants, particularly in other ethnic minorities. As I'll explain later, this particular test is predominantly being done in Caucasians. Next slide. So what have we done so far? So within this transformational project, it was really important to map the ideal pathway and then feedback these results to individual trusts. And this is because this particular pharmacogenetic test will form a foundational basis for implementing other pharmacogenomic tests into the system. The next thing we've done, and we're just analysing now, is a retrospective audit. So 7 out of 14 trusts within North Thames provided us with data on ethnicity and whether they had whether there was any toxicity, to find out whether we are missing out on any variants that we should be testing, especially those in minority populations. And we're really thankful, so we had about over 300 patients where we are analysing the results at the moment, and again we will feed back that result back to individual trusts. So all of this transformational project is linked to 13 national DPYD deliverables, and the one that I wanted to take forward was the one regarding diversity. So if you go to the next slide. So within the NHS and the National Test Directory under cancer, DPYD is present on there, and there are 4 variants that are tested, and this is great. However, there is missing information that we have, because all of the evidence that's been done has been done predominantly in European white populations, so data within other populations is predominantly lacking. So there is a long-term plan to include more variants based on new evidence. So though it is a deliverable, it's actually an ongoing plan to incorporate more research into this particular area. Next slide. So why is it important? Well, there are case studies available where severe toxicity has been picked up, and this is a case here about an Indian woman where they tested for 4 routine DPYD tests, and this was in the United States, and then she had a severe toxicity where she needed ITU admission, and on further testing through whole genome sequencing, they actually found that she had a rare variant of a DPYD mutation that has not been previously documented. And there are genomic groups within various places within the world, and this one's in India, where they're actually doing pharmacogenetic profiling for DPYD variants within the Indian population, and the same is being done in Africa as well. Within the guidelines, so in the CPIC guidelines, which I alluded to earlier, there is information to state that patients who have African ancestry should be tested for a particular variant called Y186C, which is a common variant where 3 to 5% of African ancestry patients may have this variant, and this is not currently tested. So at a national level, we are aware of this submission, and further work is going on to ensure that we have genomic testing that really ensures that the entire population that we serve is represented. So next slide. So that's the end of my slide. It's a whistle-stop tour of pharmacogenomic testing, but it gives you a nice flavour of what we're doing, and there is a lot more work coming through. So for example, we're holding engagement sessions about aminoglycoside genetic testing for particular variants, and within mental health as well. So I'll end it there. I think we're a little bit over time, and there's probably no time for questions.
I'm going to stop sharing my screen now, and I just want to say a massive thank you to everybody who has presented today. It's been absolutely fantastic.